The title of our poster is Increasing Behavioral Health Providers in Underserved Areas, a Workforce Expansion Program. There is a workforce shortage of behavioral health professionals in treating people with substance use disorder across the nation, especially in rural and underserved areas. To help address this shortage, HRSA developed funding methods for the creation of workforce expansion programs with the explicit purpose of providing advanced trainings to graduate students. This program aims to improve students' knowledge and skills in providing behavioral health care and increasing the number of well-trained behavioral health providers working in underserved areas. The overarching purpose of this workforce expansion program is to provide both evidence-based advanced didactic trainings, hands-on simulations, and clinical placements for students in the last year of the clinical placements and last year of the graduate program in the fields of mental health counseling, psychiatric mental health nursing, rehabilitation counseling, and social work. The trainings and placements are designed around providing behavioral health care in medically underserved areas with a focus on providing treatment for substance and opioid use on an interprofessional team in a practice that uses the integrated care model. In the development of this project, a team of interdisciplinary subject content experts came together to provide guidance on the important topics that students should learn throughout the course of the program. Important topics that are meant to complement their clinical experiences. This team consisted of academic and clinical social workers, nurses, psychologists, medical doctors, and higher education professionals from the schools of nursing, social work, and education, the Clinical Research Institute on Addictions, and the Departments of Counseling, School and Educational Psychology, and Family Medicine. To this end, this program has a three-pronged approach to providing training to our students: didactic, simulation, and hands-on clinical experiences. We provided a series of didactic training sessions such as interprofessional education, cultural competency, evidence-based treatment, and trauma-informed care, in addition to other topics that are listed on our poster. In addition to these didactic trainings, the students also took part in 2 simulated counseling sessions where they were able to practice their learned skills such as motivational interviewing, SBIRT, and CBT. This program also incorporates the students' existing clinical experiences in the form of field placements, practicums, internships, or clinicals. But our students are given the choices of placements that specifically follow the integrated care model in regards to the behavioral health treatment programs. This including primary care settings, doctor's offices, clinics, and outpatient and inpatient units. Our students are placed in 21 various diverse integrated behavioral health or primary care settings across 8 organizations in medically underserved areas. This program uses a mixed method approach to evaluate the workforce development program using RCQI. The qualitative approach includes 3 different aspects, including focus groups, focusing on the collecting critically and timely information regarding expectations, experiences, progress of the program, any issues, concerns, changes that could be made, how the program has or has not met their needs, and how the program has impacted them clinically and personally. In addition, trainees also partook in hands-on simulations once per semester where they are able to practice their motivational interviewing skills and receive feedback and coaching based on their sessions. Additionally, after the conclusion of each training year, we collect information from our trainees 6 to 12 months later to collect information on their career choices. Quantitatively, we take evidence-based assessments used to assess students' various learning outcomes at the beginning and end of the program. Part T test was used to examine the differences between the assessments. The following areas are the ones we assessed: interprofessional attitudes, evidence-based practice, helpful responses in counseling, motivational interviewing knowledge, cross-cultural counseling, supervision, substance use attitudes, substance abuse experience, and interprofessional collaborative competency. 64 students participated in the training program. More information in Table 1. After completing the program, students demonstrated significant improvements in various outcomes, particularly in substance abuse competency and interprofessional collaborative competency. Our students come from a diverse background, crossing both the age, gender, race, background, and discipline. As part of the focus group, data revealed that the training program was extremely helpful and meaningful to the students. An area of improvement that was noted was the students identified that they would benefit from an understanding of how the criminal justice system works, and mental health and substance use are intertwined. They felt that they don't know a lot about it while they consistently encounter it in their placements. An area of success that was noticed is that our students felt that they learned a lot they previously did not know, especially related to substance use, plus some other skills such as CBT that they were able to learn because in their interventions class it came up, they touch on it, and others in a broad way, by having the focus training that this program provided was really useful in learning it in general and how to implement it. After our students leave the program, we follow up with them 6 to 12 months afterwards to gain insight on where they are post-completion. Trainees from year 1 and year 2 have reported that the majority of them are providing treatment to individuals with SUD and OUD, providing services in integrated behavioral health settings, working in medically underserved areas, working in sites that utilize interprofessional education and/or collaboration in practice, and working in sites that utilize evidence-based practice. In addition to working in sites that provide medication-assisted treatment, with a few of them providing it themselves. A notable amount of trainees also reported that they are working with at-risk children, adolescents, and/or transitional aged youth, or adolescents and transitional aged youth in general. A few trainees also reported that they are continuing or planning to continue their education in various PhD programs. For our next steps, we will continue to evaluate our program and implement changes as they are identified. One that we have done is the inclusion of a workshop on SUD and the effects on adolescents, in addition to one that we'll be planning in year 4 surrounding telehealth for behavioral health due to the COVID-19 pandemic. In conclusion, our findings indicate that a structured addictions training program has a positive short-term impact on graduate students' knowledge and skills in delivering behavioral health care, as well as long-term impacts on their career choice in working with underserved populations. We would like to take a moment and acknowledge our clinical partners, for without them, we would be unable to function. Also, the Patricia H. Garman Behavioral Health Nursing Endowment Fund from the UB School of Nursing. This funding has allowed us to go above and beyond with our training program. Lastly, we would like to thank and acknowledge our funding agency, the Health Resources and Services Administration, who has made this program possible over this 4-year project. As a note, this content and conclusions of our own and are not to be construed as the official position or policy, nor any endorsements given by HRSA, HHS, or the U.S. government. Thank you for checking out our presentation today. Thank you, and have a great day.